Hello everyone, I am Dr. Vikas Oswal, practicing at Mumbai, chest physician, a TB specialist. So now we're going to learn something more about tuberculosis. We all know something or other things of tuberculosis, this deadly disease. You definitely have heard about the disease, but still we require to know more about the disease. Is it really required? And if yes, why? It's because the graph, if you ask me, the graph of tuberculosis right now is really going too high, and especially MDR-TB, that is drug resistant tuberculosis. Day in and day out we see cases of tuberculosis. The incidence of tuberculosis is going too high, and amongst that the drug resistant tuberculosis cases which we are seeing, especially in retreatment cases, is really touching the skies. Still we need to know more, yes, because TB is a curable disease. If it has been approached in an appropriate way, definitely even a drug resistant tuberculosis can be treated completely and patient can be cured. It's not that even drug resistant tuberculosis means it's the end stage. No, still there are good hopes to cure even drug resistant tuberculosis. How? So that's what we are going to learn all about today. First, we just classify tuberculosis. As we all know, two things, pulmonary and extrapulmonary. But in pulmonary, we are more worried for pulmonary because it spreads aerosolic, as we all know, right? It is a contagious disease where the bacilli, they just spread to each other, that is from a patient to a healthy individual, just through aerosols. When I cough, when I sneeze, or when I yawn, or when I talk too closely, and if I do not cover my face while doing these actions, and if I am an infected patient, definitely I am going to pass on my bacilli to an healthy individual. If the individual's immune system is on the lower side, even he is going to have tuberculosis. So that's the reason we are more worried for pulmonary tuberculosis. This is nothing but pulmonary tuberculosis. Next, extrapulmonary tuberculosis. Each and every site or the organ or the system of the body, head to toe, other than hair and nail, do have tuberculosis. Let it be lymphatic system, let it be pleura, let it be abdominal tuberculosis, let it be central nervous system, let it be genitourinary tract system, let it be a skeletal system, the bone, the vertebrae, the joints, or let it be cardiac. So we do find tuberculosis at each and every site. Knowing these sites are very important because that's when you're going to have a right approach for your particular case. We all know this, that one single cough, we release bacilli. We release some amount of organisms in air. But do you know how much? It is approximately 3,500 to 4,000 bacilli which we release in one single cough. Now just imagine, in one single cough, if I am releasing 3,500 bacilli, and if I am not covering my face at that particular moment of time, obviously I am not going to cough once. If I am having cough, I am going to cough at least for 3, 4 or 5 times. Now this action, 4 coughs in one episode, that means I have definitely released at least 16,000 bacilli in one single episode of cough. One single bacilli entering my system, and if my immunity is down at that moment of time, even I am going to have disease, yes. Not only being infected, but I'll be diseased, where I'll be requiring treatment for myself. We all advise our patients to cover our face while coughing. Yes, even you are doing that. But dear friends, I would really like to ask, how many of us show them how to cover their face while coughing? Because when we just tell them by mouth that please cover your face or mouth while coughing and sneezing, the message which they take home and the action which they actually perform practically on field is or maybe sitting in your chamber right in front of you, they might just be doing this. They think that they haven't showered bacilli to you, but no, that's not the right thing. Now these are the actual photographs which have been taken by cameras. You can see it very clearly. Just by doing this, a person has actually directed these bacilli in 4 different directions, and these bacilli are going to be there in this room or my chamber at least for another half an hour or 45 minutes. So it is really important to, if you really want to convey this message and to reach them appropriately, do not only tell but show them that you require to cover both your nose as well as mouth while coughing. This is very important. A small action will make a lot of difference. We all know about droplet nuclei. How do tuberculosis spread? Yes, TB bacilli, so called, is hardly of 1 to 4 micron in size. You know, it is actually 100 size of your single hair. Now just imagine how small it is. Yes, it cannot be seen by our naked eye. So that's the reason we require some special microscopes to actually visualize these bacilli. Now these bacilli, they are n number of bacilli in one single droplet of cough. That is, if I cough and if one single droplet goes and settles down somewhere, that one single droplet carries hundreds of bacilli in it. When this droplet evaporates, it's going to release all bacilli in air, which will be open and which will be actually entering my system at that moment of time. That's the way how a infected person shares a bacilli to an healthy individual or a normal individual. That is to droplet nuclei. Cough etiquettes outside India, yes, they do follow this technique. They snugly fit their nose and mouth by their elbow joint. That's this way. But I would advise that still in India, I would still recommend to cover it both this way and not this way, because maybe the action sometimes would be interpreted or taken in a wrong way, and then they would not solve the right purpose of covering their face while coughing. That is, maybe they do this way, which again won't be a right thing. This is a pictorial graph which is showing how the bacilli spreads aerosolically from an infected patient to an healthy individual. All sites of tuberculosis, that is bone TB, joints, vertebrae, rest all sites, very important. Yes, extrapulmonary, a lymphatic system. Lymph nodes, that is supraclavicular lymph nodes, or maybe axillary lymph nodes, or maybe inguinal lymph nodes, or maybe mesotic lymph nodes. They are the worst thing. Oh yes, cervical lymph nodes. You require to have appropriate approach to for each and every case as per the case. Pleural effusion, that is the fluid which is outside in the pleural space. Yes, the tubercular pleural effusion. Let it be tubercular meningitis. Symptoms, we all know about it. That is cough, evening rise of fever, sweating, blood-stained sputum sometimes, night sweats, decreased appetite. All this, yes, they do give us an indication that patient might be suffering from tuberculosis. These are some of the high risk group population, that is pregnant female or drug abuser, alcoholic, or having tobacco since a long time, cigarette smoker, or a malnourished child, or a immunosuppressive patient who is on dialysis or who is on some immunosuppressive agents, or geriatric patients. Oh, if I say one single cough releasing 4,000 bacilli, now just imagine what these people are doing. By spitting, not even bothered that they are not releasing only bacilli, but they are actually calling so-called tsunamis in their areas. Now, this is a major challenge what we all are facing, that is slums. Yes, where these slums are absolutely poor ventilation, they don't have proper ventilation, no sunlight, there is no sunlight. Plus, due to the spray crunch, what we have found is approximately 6 to 7 members staying in an average of 120 square feet area. Yes, these are the actual figures which are from these slums. The average number of people staying in one single 120 square feet area are around some 6. Now just imagine how overcrowded these places are. Their homes, which don't have even a single window for a fresh air to come in and carry this bacilli out. There is only one single entry door, which from where a patient, family member or guest, each and every enters to the single door and exits to a single door, releasing whatever organism they want in that small area. Mask, surgical mask, not advised specially for us or health workers Absolutely no. This would definitely not protect us at all, because the pore size of the surgical mask are too big to welcome all the bacilli, where bacilli will definitely still be transmitted to others. It is only 20% of the bacillary population which still would be filtered through the mask. Rest 80% can still cross the pore size of the surgical mask. If you really want to get secure, this is the only answer, that is the respirators, as we all know. Ventilation, nothing but like it, a natural ventilation where you have a good cross ventilation in your chamber, in your home or your patient's house. That is the thing which you require to just convey to your patient. If they don't have a provision of natural ventilation, at least go for an artificial ventilation even in your chambers. This will also definitely help. Try to build up a negative pressures in your chambers where the air is being sucked out and been thrown out, and there is an influx of a fresh air coming through somewhere else. Let us move towards the management. Before going to management, let us just highlight some of the definitions, that is MDR-TB. What is MDR-TB, or what is, first I would like to say, mono-resistant TB? When a single drug other than rifampicin, if the isolate is resistant to one single drug other than rifampicin, it is mono-drug resistant. And these I am talking about first line drugs, that is out of isoniazid, rifampicin, pyrazinamide, ethambutol. If the rifampicin is sensitive and if any of the drug other than rifampicin amongst first line drugs are resistant, one single drug is resistant to the particular isolate of the organism, leaving rifampicin, it's a monodrug resistant tuberculosis. Rifampicin resistance tuberculosis, or we do also label as MDR-TB. Now, there is a difference between rif resistance TB and multiple drug resistant TB definition wise. Multiple drug resistant TB is nothing but when the isolate is resistant to both rifampicin and isoniazid drugs both together. It is called as MDR-TB. Still, on GeneXpert, when we get rif resistance on GeneXpert, still we label these patients as MDR. The reason being, 95% of the population who are resistant to rifampicin are also resistant to isoniazid. That is the reason we are not bothered for the 5%, but these 95% are still going to have expanded resistance to isoniazid also, and that is the reason even for these rif resistant cases we do label them as MDR-TB and start second line drugs for these patients. Next is XDR-TB, that is extensive drug resistant TB, when you have a resistance to rifampicin isoniazid and an added resistance to FQs, that is fluoroquinolones, and second line injectables. Yes, the patient is XDR-TB. There is something called as pre-XDR-TB, but definition doesn't exist in the guidelines. Pre-XDR-TB, when you have a resistance to either of FQs or one of the second line injectable, it is called as pre-XDR-TB, a stage just prior to XDR tuberculosis. Now, many of us see in field that we do prescribe, or we do see prescriptions in field that radiologically been diagnosed as MDR-TB. Now let me make one thing very clear over here, dear friends. There is no radiological diagnosis for MDR-TB or any drug resistant tuberculosis other than microbiological diagnosis. You definitely cannot diagnose a drug resistant tuberculosis only on basis of X-ray chest or a CT scan films. No. And if you find such prescriptions in field, definitely we are going somewhere on a wrong track. This is one of the example where we have actually cultured these patients, and you will be shocked and surprised to see the first X-ray which is having minimal infiltrations, but this patient was proven as XDR tuberculosis. The second X-ray, as you can see, there were hardly some infiltrations on the apical zones, but this patient was being diagnosed as MDR tuberculosis. The third X-ray, where there are extensive infiltrations seen on both the sides, this patient, the susceptibility was, he was resistant, not resistant, but he was susceptible to all first line drugs as well as second line drugs, and he was turned out to be drug sensitive TB. The difference itself tells me that these DSTB or DR-TB or DST doesn't matches with the X-ray or the pictorial radiological diagnosis. That's the reason I'm telling you all, it is definitely not a right way to diagnose DR-TB unless you have a genotypic or phenotypic method done for your culture isolates, or maybe a molecular test for your patients. Now, what do you mean by molecular test? Molecular test consists of gene expert. Now, this gene expert or CBNAT, both one and the same, that is cartridge based nucleic acid amplification test, also called as, there is one more test which has come up now, TrueNAT, which is a chip based nucleic acid amplification test. Happy to share that this TrueNAT is nothing but by us, made in India and by us Indians. That is, an Indian company has come up with this TrueNAT, where even RNTCP have definitely approved and endorsed, started giving this TrueNAT also, and it has been included in the guidelines right now. So initially it was only CBNAT, but now we have both CBNAT as well as TrueNAT, where we can perform upfront nucleic acid amplification test for all the samples. That is gene expert. Second, LPA, that is a second molecular test, line probe assay. This line probe assay, there are two types of line probe assay. One is for first line drugs, isoniazid and rifampicin. Second is for second line drugs, which will give you an idea of quinolone groups as well as second line injectable groups. And amongst these groups, which of the drugs would be sensitive or resistant, that we definitely can make out through the further mutations or reading these further mutations, that we will see later. Third is a phenotypic method, where we do a culture of these bacilli, we grow the bacilli, and then we perform a DST, that is drug susceptible test on these culture isolates, where we get an idea of each and every drugs, whether the particular drug is sensitive or resistant, which will really help us to make an appropriate regime for our patients. So that's the only way to diagnose your DRTB and not radiologically. That's an algorithm which, if you just keep this algorithm in mind, half of your things are sorted. Presumptive TB, all notified TB, or non-responders who are already on treatment but still not responding. Let it be any cases, direct them directly upfront for NAT, that is nucleic acid amplification test. You do perform a gene expert in these tests, and you do go ahead as per the results. Now this is gene expert, a machine and a cartridge, where this cartridge goes in a machine and you get a report within 2 hours of time. Similarly, even for TrueNAT, it's a chip based machine where this cartridge is not been used, but there is a chip which is used, with a chip machine goes in the machine and gives you a result in lesser than gene expert, the CBNAT machine, that is only in 1 hour. That's the benefit over gene expert CBNAT. TrueNAT can also be used on a battery, that is, it has a battery backup. So it can be kept in any primary health centers or any of your clinics and dispensaries. That's the reason now government is planning to shift all his CBNAT to TrueNAT. This is how the machine generates a report. It gives you a report telling you about whether the TB, that is Mycobacterium tuberculosis, is present or absent. Not only that, it also gives an information whether the particular organism which has been detected by this gene expert, is it sensitive to one single drug, rifampicin, or no. This will help you a lot to distinguish your patient immediately, that whether you are dealing with a sensitive case or a resistant case, that too within just 2 hours of period. You can use each and every samples for gene expert, though the company Cepheid themselves, they do tell that we recommend only sputum, but still WHO have endorsed each and every samples for gene expert other than blood, stools and urine. These are the 3 particular samples where we don't send usually for gene expert. Rest all other samples including CSF fluid, pleural fluid, abdominal fluid, or maybe lymph node, or maybe a bone biopsy, or maybe any other biopsy, or maybe a joint effusion, or maybe sputum. Let it be any body sample can be sent for gene expert. But mind it, do not send sample in formalin. Kindly send the sample in normal saline. Second, stool and urine are also in pipeline to get endorsed very soon by WHO, but till now we don't send stool and urines for gene expert. Blood samples cannot be sent for gene expert. Though the sensitivity of each and every sample is different, it has a best sensitivity for sputum, which is around 98%, whereas it goes down for fluid, that is ascitic fluid or pleural fluid, it is hardly 30%. But still it is better to send these fluids for gene expert, because at least the 30% of patient will still get benefited whether they are sensitive or a resistant TB. This is how you get a report which tells you about MTB detected or not detected. Now this report is MTB not detected, but a negative report doesn't mean that patient is not having tuberculosis. Be very cautious before commenting to your patient. The moment you get MTB not detected, it could be because maybe the sample was inappropriate, maybe the sample quality was not good, maybe the sample have not come from an expected site, that probably the cavity was on right apical zone, the sputum sample would have come from left apical zone or some other segments. Maybe while taking a biopsy, the needle have gone through and through instead of getting in the core of the lymph node, and that would be the reason of this report coming negative. So the message over here would be, negative report should be considered and taken with a pinch of salt. Negative report doesn't mean that patient is not having tuberculosis. You require to either repeat these tests, or maybe you require to wait for another test to give you the report. These are the positive reports which will tell you MTB detected, that is Mycobacterium tuberculosis is been detected through this gene expert. Positive report are never wrong. Once positive, yes, the patient is positive over here. The second band, which is a green colored coded band, it tells me rifampicin resistance not detected. That means the patient is sensitive to the most important bactericidal agent, that is rifampicin. The patient is a sensitive case and not a resistant case. This patient would definitely require only first line drugs. Do not add any second line drugs for the management of this patient. Third, if you just notice over there, there is written over there MTB detected very low, medium, high. Now this is nothing but the bacillary load which is there in the particular given sample. A message to be taken over here, one more thing, gene expert can never be done for follow up cases. Mean you don't require to send gene expert for a patient on treatment since 2 months or 6 months unless you suspect a resistance for the patient, because once gene expert is positive, it is going to remain positive. It catch hold of DNA of a patient and then gives you an answer. The same DNA would be present even on dead bacilli. So you will get misguided if you have again a positive gene expert which has been sent by you at the end of the treatment, which if it comes positive, that doesn't mean that patient is still active. The positive report at the end of 6 months would just be that the DNA of the dead bacilli has been picked up and you have got a positive report. Unless you have a culture positive at the end of the treatment, do not consider the treatment as a failure. So that means gene expert, very good investigation, but not appropriate investigation for follow-ups. Next is LPA, line probe assay, a second very beautiful molecular method of diagnosing tuberculosis. The way gene expert tells me about a RIF resistance or sensitivity, this LPA gives me an idea for both rifampicin and isoniazid together. That is, if I send LPA for first and second line drugs, the patient, that a Heinz test, it gives me a report whether rifampicin and isoniazid both are sensitive, or either one is sensitive or either one is resistant. That is LPA Heinz test. We will see further how to interpret this report. LPA also picks up a DNA, it replicates through a PCR technique, polymerase chain reaction, and then gives you a report which is a line, which is a sort of a line which you see on the report, and that's the reason it is called as line probe. That is, you see multiple lines on this probe, which will give you where exactly the mutation have occurred on the particular code or codons, and that is the way you interpret these reports. So the moment you get RIF sensitivity on Gene Expert, immediately we do send first line LPA to look for isoniazide rifampicin, isoniazide sensitivity, whether the isoniazide, which is the second most important bactericidal agent, is sensitive or not sensitive. The moment both this rifampicin and isoniazide are found sensitive, you just directly subject the patient on FDCs, that is fixed drug combinations. Depending upon the weight of the patients, we do decide the number of pills to be given in FDC as per the weights. So these are the charts, weights for the pediatric patients to be given. If the patient is unable to tolerate his FDC, then we also can give a per milligram kg body weight, calculate per single drug and give them separately. The best way to remember this would be IRESP mnemonic or IRESPIRE. Just put 5, 10, 15, 20, 25 into the body weight of the patient, and whatever the answer is your per milligram per kg body weight. Why do we send LPA if still our Gene Expert was sensitive? The reason is we have learned from our history. This is category 1, we all know, 2 months of HRZE where a ZN smear was negative and we shifted the patient on 4HR. In those days we never had LPA, Gene Expert or cultures with us, so only on base of a ZN smear we used to treat our patient, start the patient on treatment, shift him from IP to CP and also declare them cure, even without knowing the cultures or the DST pattern of the particular organism. Now this is what had happened actually. You might have seen there would have many patients who had taken a AKT before in past, who had taken category 1 or 2 in past and who had come to you with resistant case now. Why does this happen? Because maybe there was an initial resistance to isoniazide. Meta-analysis have proven that is globally 12 to 18% of the population are resistant to isoniazide. That is, now just imagine if this case would have been an INH resistant case and you had shifted this case from IP to CP, that is 4 months of HR, and if there was a baseline H resistance in this case, that means indirectly you have given him only rifampicin for 4 months. As we all know, a single drug is insufficient to fight this organism. That's the reason we have augmented somewhere the resistance to rifampicin also unknowingly. Not only that, when the same patient approached with a sputum ZN smear positive again after 1 year, we subjected the same patient on so-called category 2. Now just imagine the baseline of this patient where H and R was resistant, but we never had Gene Expert or cultures those days, and we somewhere landed up giving continuation phase of 5 months only ethambutol, one single drug, similarly augmenting the resistance to ethambutol also. Unfortunately, now also we haven't stopped over year 2. We see prescriptions in field only on basis of X-ray chest. They do prescribe only FDCs with moxiflox, or maybe 4 AKT4 with quinolones, or maybe 4 cox along with leoflox. Now just imagine just adding of one single second line drug to these failing drugs. What's going to happen? Yes, we are going to augment the resistance, not only making MDR but also pre-XDR and XDRs over here. This is how the Gene Expert tells me a report of MTB detected medium and RIF resistance detected. The moment you find this, immediately send a sample for LPA, first line, second line as well as LCDST. Now let us touch something upon LPA. Heinz test, that is LPA first line, which tells you about isoniazide and rifampicin both together, whether the patient is sensitive to rifampicin, yes or no, and whether he is resistant to isoniazide, yes or no. Not only that, in isoniazide there are again 2 mutations to be seen, that is INHA mutation and CATG. The moment you have CATG mutation, INH in any form is not going to be useful for your patient. You cannot give INH in any form, not even high dose INH for your patients. The moment you see a CATG mutation, just remove INH from the regimen. Second information what you get from this LPA first line report is INHA mutation. The moment you have INHA mutation present, the same patient, ethionamide is not going to be of useful for your patient. You cannot give ethionamide for your patient. Now this is how, the moment you get H resistance, we send the sample for second line LPA and LC-DST and we start the patient on. If the patient was sensitive to rifampicin but resistant to INH, now these are the cases which are INH mono resistant case, who are sensitive to rifampicin but resistant to isoniazide. Immediately send a sample for second line LPA, where you will get information of quinolone or SLI working or not working for your particular isolate. The moment you get an information that yes, FQ and SLI are sensitive, that means you just have to do is what? Just replace INH with levoflox, and the regimen over there for mono drug regimen, mono drug resistance cases would be only levoflox, rifampicin, ethambutol, pyrazinamide, all these 4 drugs for 6 to 8 months of period. Minimum 6 months, you can extend as per the case individual if required for even 8 months. But 6 months are more than sufficient. No IP or CP, pyrazinamide to be continued till the end. But kindly be reassured that FQ is working over there by second hand LPA report. The moment it is RIF resistance and added resistant to INH also, yes, these are nothing but a proven MDR-TB who are resistant to isoniazide and rifampicin. These cases, just check for the history of this patient, whether the cases are pulmonary cases. If extrapulmonary, are they lymph nodes or are they pleural fluids or ascitic fluid? Just ask for history, whether is there an exposure of quinolones for more than 1 month in past. Ask for a pregnancy history and ask for any XDR-TB contact. If the answer is no, very good, that means your case is an ideal case for shorter course regimen. Now what is this shorter course regimen? It is also called as Bangladesh regimen, but to go ahead with shorter course regimen, you require to have sensitive to both FQ and SLI. Both these groups of drugs should be sensitive for your patient. That is the only case which will be sensitive to or can be applicable for shorter course regimen. The benefit of this regimen would be, instead of giving second line drugs for good 18 to 24 months, shorter course regimen decreases the number of days to just 9 months to 11 months of treatment for second line drugs. But be rest assured that your INH rifampicin is resistant, but FQ and SLI are sensitive. Next, if you find added resistance to FQs or SLI on LPA report, these are the individuals who are not at all eligible for shorter course regimen. These are the cases where you will have to directly wait for LC-DST report also, and depending upon the DST report, these cases are being subjected to all oral longer regimen. You don't require to wait for the DST to come, but the LPA report itself will guide you to make an appropriate regimen for your patient. Depending upon the LPA report, you can definitely know whether quinolones, amongst quinolone group, whether you can give levoflox to your patient or moxiflox regular dose, or you can give moxiflox high dose to your patient. This can be interpreted depending upon the level of mutation which have occurred in the patient. So that is how you interpret the report. We will study it in detail now. So the moment the patient is not fit for shorter regimen, the short course regimen which is of kanamycin, moxiflox high dose isoniazide, ethionamide, clofazimine, pyrazinamide and ethambutol. There are 7 good antibiotics for a period of 4 to 6 months, and a CP phase of just moxi, high dose, clofazimine, pyrazinamide and ethambutol. Now let us come to all oral longer regimen. As the name suggests, all oral, yes. The good news is the patient would no more take any injectable, that is kanamycin or caprimycin. Yes, we have just withdrawn kanamycin and caprimycin from the regimens. Now this was not been just withdrawn over the day or over the night period. There were meta-analysis and studies which have proved that these drugs, when the SAE were being studied, there were a lot many side effects for these particular drugs. That was the reason of removing these injectables from the groups. Now this is a new group of drug classification of the drugs, that is group A, B and C. Group A consisting of quinolones like levo and moxiflox along with bedaquiline and linezolid. Group B drugs are cycloserine, clofazimine, and group C drugs are rest all other drugs like ethambutol, pyrazinamide, then delaminid, imipenem-cilastin, amoxiclav, amikacin, PAS. Yes, these are the groups who are less potent drugs who are being kept in the group C. These groups will definitely help you a lot to design a regimen for your patient. How do we do that? Just include group A and group B drugs as per the LPA report. The baseline all oral longer regimen have a newer drug in it, that is bedaquiline. Instead of kanamycin, we are using bedaquiline over here. So the regimen becomes bedaquiline, levoflox, clofazimine, cycloserine and linezolid. That is all three drugs of group A and two drugs of group B, that is clofazimine and cycloserine. The moment you get resistance of either of these groups of quinolones, then the time comes for replacement of the drugs. For pediatric patients, we don't use bedaquilines at present in India. So in India, more than 18 years of old are benefited with bedaquiline, whereas the age group from 6 to 17 years of age, pediatric cases, we are giving them delaminid instead of bedaquiline. The regimen remains same, that is delaminid, levoflox, linezolid, clofazimine, cycloserine. The bedaquiline drug, a newer drug with a half-life of 5.5 months, we have a good import of bedaquiline in India right now. That is the reason probably we have already started planning shifting from a conventional regimens to all oral longer regimens. Delaminid, a half-life of 36 hours, yes, a very good drug for a pediatric age groups. Now this is how we can interpret your LPA report. Just check for the level of mutation happening. There is something called as for quinolone resistance. Check for gyri A, gyri B gene mutation. If there is a gyri A mutation being seen and if the mutation is present till mutation 3A, that is if the mutation is present amongst mutation 1 band, mutation 2, mutation 3A, these are the patient, if the mutation is seen on these three codons, these patients are resistant to levoflox. We cannot give them levoflox, but if there is absence of mutation on 3B, 3C, 3D or gyri B, mutations are absent, they are the candidates where you can definitely give moxiflox instead of levoflox. Moxiflox low dose would be sensitive, would not be sensitive, will be confirmed, reconfirmed by LCDST, but these cases can you surely think for moxi high dose, and once the LCDST report is available, you can decrease your moxi high dose to low dose or regular dose moxiflox if it is sensitive on LCDST. The moment you have mutation present on 3B, 3C, 3D, or if you see mutation on gyri B mutations, that is gyri B mutation 1, mutation 2 present, these are the candidates who definitely won't be benefited even by moxiflox high dose. there is no point adding moxiflox to this patient. You will have to think for a substitute for the moxiflox or quinolones in these particular patients. Let us come to second line injectable, where we have moved from injectable to all oral longer regimen. Still there would be a need of second line injectable in a case of replacements of the drugs, where you will see RRS mutation. If the RRS mutation is present, none of the injectable will be working for your patient, whereas if there is RRS mutation absent and if it is only EIS mutation present, you definitely can give amikacin to these patients. These are the chart for appropriate drug dosages as per the weight of the patient. You can just go through it. Only drugs won't help unless you back up your patient with thorough counseling and give a palliative care. This counseling should be done thoroughly for your patient in front of the family members. They do require complete support of family as well as the nutrition, good nutrition. Palliative care, yes, rehabilitation, because many times even after treating tuberculosis, you do require to take care of the permanent damages that is supposed to be sequelae which develop. Let's join hands together so that we just save this a young chap who has been surrounded by these such kind of resistant tuberculosis everywhere. It is not possible to fight this battle individually. We all require to join hands if you really want to win this battle of deadly tuberculosis. Thank you.
Sanofi presents a cutting-edge formulation. Fexofenadine plus montelukast, bioequivalent bilayered tablets. Olegram, the fastest, non-drowsy third generation antihistamine for uncontrolled allergic rhinitis and persistent allergic rhinitis. Superior efficacy than levocetirizine plus montelukast, on ARIA recommended properties. Drugs and excipients are mixed to prepare a dough mass. The dough mass is dried to the desired moisture content. The dried material is milled to get desired granules and flow characteristics. Dried granules are mixed with other extra granular materials and lubricants. In the compression machine, fexofenadine is loaded in one hopper and montelukast in another hopper. Fexofenadine is compressed first, followed by montelukast granules to prepare a bilayer tablet. Processed under bilayer compression technology and progressive coating to avoid drug degradation. The coated tablets are checked for complete analysis, avoids chemical incompatibilities. Allegra M has been endorsed by the Indian Journal of Pharmaceutical Sciences to be recognized for its significant innovations.